All right, welcome to Brain Health with Dr. Nissen. Today we are going to be discussing ketamine, which is a medication that's been used in anesthesia for a long time and has very recently been having some very interesting results published in psychiatric studies. So before we jump into this topic, I do want to read the bottom of the slide here, which says that this presentation contains discussion of experimental and illicit substances. This presentation is meant for general informational purposes only and does not constitute the practice of medicine or other healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. This presentation is not meant to advocate for the use of illicit substances. It is recommended that you do not use illicit substances or perform any other unlawful act. So, what is ketamine? Ketamine is a dissociative anesthetic that's been used in anesthesia for decades. It was approved in 1970 for anesthesia use. It is a Schedule III controlled substance, and it has psychedelic properties, and that's why it's been in the news a lot lately, in addition to its antidepressant properties. So ketamine has these psychedelic properties like that it's considered mind manifesting. It has ineffability and ego dissolution as some of its subjective properties that are used in psychedelic studies. It's not serotonergic, but is rather a glutamate antagonist or blocker. We'll go more into the mechanism of action in a bit, but this is important, especially in the context of comparison to other psychedelics where many of them do have serotonergic properties. Ketamine has varying uses depending on its dose, and at the higher doses for several decades it's been used for procedural sedation, and it's also used in acute agitation as well. The first trial supporting the use of ketamine for depression was published in 2000. So ketamine is considered an essential drug by the WHO for anesthetic use and its cardiovascular stimulatory effects. So the fact that it can increase blood pressure and heart rate is very important in procedures, especially those where there's a lot of blood loss. Several other sedating medications cause drops in blood pressure and pulse, and ketamine does not. So how does ketamine exert its effects? It's not fully understood exactly how ketamine exerts its antidepressant effects, but it is a non-competitive antagonist of the NMDA glutamate receptor. So it binds to a specific site within the NMDA receptor ion channel pore, and this prevents the influx of calcium ions. The glutamate release and synaptic plasticity that results after this is what is thought to have the antidepressant effects. The blockade of the NMDA receptor leads to increased glutamate release from other neurons, increased BDNF release, which is brain-derived neurotraffic factor, otherwise known as Miracle-Gro for the brain. It helps with the generation of new neurons, and thus this increased synaptic plasticity, so ability for new learnings, ability to integrate new insights. And this particularly happens in the prefrontal cortex, which we know is very important in the regulation of mood and in cognitive processes. So the downstream effects of this is that the increased glutamate release and the synaptic plasticity triggered result in various intracellular signaling pathways, including the mTOR pathway. So all of this together creates better synaptic connectivity, neuroplasticity, and the regulation of mood-related processes. So what is the role of opioids in ketamine, in the ketamine mechanism of action? So it's actually thought that ketamine does have some sort of opioid effect as well that contributes to the antidepressant effect. And this is related to the study by Matthew and colleagues in 2019, as well as a few others that have looked at the pre-treatment of ketamine folks with naltrexone, which is an opioid blocker. And in doing this, they found that there's an antidepressant, anti-suicidal effect of ketamine that was diminished without blocking the dissociative effect. So by giving naltrexone, blocking the opioids, it seemed like ketamine was a bit less antidepressant and a bit less anti-suicidal, but it still produced the same dissociation. This wasn't found to be the case for the long-acting injectable version of naltrexone, but is an interesting finding nonetheless. It leads us to think that the mechanism of action for ketamine includes the NMDA receptor antagonism. It includes possibly an opioid component of it, and then also includes the role of the active metabolite known as HNK, which I'll talk about. So ketamine structure is an aryl cyclohexylamine, which makes it related to PCP, the street drug. It is metabolized by the liver, and it has this active metabolite, which I just mentioned, hydroxynorketamine, or HNK, that has its own antidepressant effects that are independent of the NMDA receptor activity. It's been used in both racemic formulations, which means a combination of the R and S ketamine enantiomers, as well as the S enantiomer only, which is S-ketamine, or Spravato is the brand name, which you may have heard of. So this leads me to the next point. What is the difference between S-ketamine and R-ketamine? How do they compare to one another? So a study by Yang and colleagues in 2019 or 2015 did a good job talking about the S enantiomer and how it may drive the addiction or abuse potential. So this mouse study, what they did was they were looking at differences in self-administration of ketamine, which is indicative of addiction or addictive potential. If a mouse continues to return to self-administer the drug, it's thought that it does have more abuse potential. And so what they found is that the mice were able to self-administer the racemic ketamine quite often, demonstrating the addictive potential, but they did not do this for R-ketamine. So this suggests that R-ketamine does not have the addictive potential, but that racemic, or a mix of R and S, does, which means that maybe it's the S-ketamine component, or S-ketamine, that does mediate the abuse potential here. And this is a really important finding. In addition to this, in a preclinical model of depression, it was found that R-ketamine had greater efficacy for depression, and that R-ketamine has lower risk of psychotomimetic side effects, which means may have lower risk of triggering a psychotic episode. So putting this all together, it looks like it's really R-ketamine that does have robust antidepressant effects, or maybe more robust antidepressant effects, but more importantly, it may have lower risk of addictive potential and of triggering psychosis or psychotomimetic side effects. So a very interesting study there talking about the differences between S-ketamine and R-ketamine. So what are ketamine's pharmacokinetics? How does the body change its impact? So ketamine can be ingested orally. However, it's not very effective that way because, or rather you need to take higher doses because there's a large first pass effect in the small intestine and liver. Only 17% of what's consumed orally is bioavailable, and this is partially related to the cytochrome P450 enzymes involved in the first pass effect. So the oral component is also subject to more drug-drug interactions, which we'll talk about in a moment. The intranasal formulation, which is often seen for S-ketamine, the nasal spray, it has 40 to 60% bioavailability, and this is due to a mix of intranasal absorption, but also some degree of intestinal absorption, which, as I already mentioned, has low bioavailability due to the first pass metabolism. So, intranasally 40 to 60% versus 90% bioavailability of intramuscular and 100% bioavailability of IV ketamine. So the half-life is short as well. It's 2 to 4 hours. So, looking at bioavailability alone, intramuscular and IV ketamine definitely have the upper hand, but it's sort of moderate with the intranasal, so it makes sense that that's an option as well. So what are the roles of the cytochrome P450 enzymes on ketamine? This is important when considering oral ketamine intake. So the cytochrome P3A4 and cytochrome P2B6 inhibitors increase oral bioavailability. So this includes clarithromycin, ticlopidine, and grapefruit juice. So all of these, if you're drinking a bunch of grapefruit juice and then you take oral ketamine, you have the risk that more of the oral ketamine makes it to your central nervous system and that you have stronger effects. versus CYP inducers, they decrease the PO bioavailability. So if you're taking St. John's wort or rifampin, then you would have to take a larger dose of PO ketamine in order to have a similar effect. What are some potential drug interactions? Well, it is known that GABAergic medications can blunt the antidepressant effects of ketamine. So for GABAergic medications, we consider benzodiazepines. Very commonly, people are using alcohol, which is also GABAergic. And then some other medications like lamotrigine, memantine, clozapine, and risperidone do have some components that can contribute to this blunting of the antidepressant effect of ketamine as well. So somebody that's taking something like clonazepam at the same time as they would take the ketamine might not notice much of an improvement in their depressive symptoms. The good news about ketamine is that there are minimal interactions with antidepressants like SRIs, bupropion, mirtazapine, MAOIs, and TCAs, as well as lithium valproic acid used in bipolar disorder, and stimulants. So this is really good news because for several of the psychedelics and for a few other interventional psychiatric treatments, these very common psychiatric medications could be an issue, but they're not really an issue with ketamine. So how does IM ketamine compare to IV ketamine? Well, IV ketamine is kind of pretty predictable. Here you have somebody in an infusion suite and they get a slow infusion over 40 minutes, and so they sort of have a steady trip. In comparison, for IM or intramuscular, it tends to be a bit peaked. And so you can see that in the bottom right here. You see the dotted one going up is the intramuscular. So a very quick increase in plasma concentrations and then a very quick decline as well. For IM, it peaks 7 to 10 minutes after the injection, again with these rapid reductions in plasma concentrations, and so a quicker return to the psychological baseline. So for this reason, often they use a booster dose to sort of extend out the duration of the treatment. IM, though, does have its benefits in that it's pretty convenient. You don't need an infusion suite. It can be done in an outpatient practice. So that's definitely a benefit. But IV, kind of has a bit of a smoother sort of experience for the patient, and not as much of this up and down. So how is ketamine dosed? So ketamine is dosed differently depending on whether it's being used in a depression or psychedelic sort of setting versus an anesthetic setting. So at doses of 0.2 to 3 mg per kg, this is the dose that's being used for a lot of these psychedelic effects. The lower doses produce sort of mild dissociation that happens from 25 to 50 milligrams intramuscularly. And then for 75 to 25 milligrams intramuscularly, there's more intermediate dissociation or psychedelic effects that are kind of, what's described in many of the papers that I'll be discussing. For higher doses of 150 to 250 milligrams intramuscularly, there's more severe dissociation and more of this sort of K-hole-like experience that's a bit more profound. From 3 to 13 milligrams per kilogram, this is what's considered a higher dose. It's what's used in anesthetic or sedative sort of contexts. So how does the ketamine experience compare to psilocybin? As this sort of debate goes on of ketamine as a psychedelic, which I think I'll describe it for many reasons. I do think that it is a psychedelic. It's important to compare to other psychedelics and see what's in common and what's different. And there's a really great paper that I'll bring up on the next slide that compares those similarities and differences in the subjective experience of the person. In general, what you see is that psilocybin has more of these sensory distortion or changes in perception, sort of imagery, or seeing things differently, or changes in perception, versus ketamine has more of this disembodiment or the dissociation that's described as a dissociative anesthetic. Both have components of this blissful experience, spiritual experience. So here is box 1 from Vollenweider and colleagues in 2010. Again, really great paper looking at the differences in subjective experience between ketamine and psilocybin. Psilocybin is on the left here and ketamine is on the right. So as you can see, for psilocybin, there's more of this elementary visual alterations, audiovisual synesthesia, vivid imagery, versus for ketamine, there's more of this disembodiment that's noted. Both of them do share this blissful state, experience of unity, and I think that's kind of the overlap that kind of makes ketamine be considered a psychedelic, among other things, but the experience of unity and sort of ego dissolution. So let's talk about some of the outcomes that have been seen in the research and in clinical trials for ketamine. What research has been done on ketamine for depression? Well, there are a few key depression studies. The first one being in 2000 by Berman and colleagues. This was a pioneering study because it was demonstrating the rapid antidepressant effects of ketamine, probably at the earliest. And so they were looking at a single IV infusion of ketamine in individuals with treatment-resistant depression and found a significant reduction in depressive symptoms within hours after that single infusion. For Zarate and colleagues in 2006, they found that a single IV dose of ketamine produced rapid antidepressant effects within 2 hours and lasted for up to 7 days. And again, that was an RCT. And in Newport and colleagues 2015, again, they were looking at the effects of repeated IV ketamine infusions on depression symptoms and found a significant reduction in depressive symptoms that lasted for up to 14 days. Murrow and colleagues in 2013, again, another randomized RCT that was looking at a single IV dose of ketamine and did demonstrate a rapid and significant reduction in depression symptoms within 24 hours. Daly and colleagues in 2019, a meta-analysis, kind of putting multiple studies together and concluded that ketamine demonstrated a significant and rapid antidepressant effect across multiple studies. So a lot of sort of repeated effect noted, good replicability of the outcomes. So, to put it together, ketamine for depression, ketamine demonstrates robust and rapid antidepressant effects. The effects are most prominent in the first few days, and that's sort of an ongoing area of discussion, is how long are these effects and what happens when, the person no longer is getting the ketamine. But these effects definitely, are occurring very rapidly and are, positive for antidepressant effect. The single dose does have a rapid antidepressant effect, which is helpful because it's easy to identify non-responders. If you compare this to taking a typical SRI antidepressant where you have to wait, 4-6 weeks, to really know whether or not there was this benefit. This is, you can know immediately whether the person's a responder, and approximately half of people will be. And the treatment regimen studied is typically looking at 2 to 3 ketamine sessions per week for 2 to 6 weeks, followed by maintenance dosing of once weekly, and then after that, once every other week. And this is interesting because it's very similar to electroconvulsive therapy or ECT, where people do have sort of more intensive treatment, and then they space out those treatments, and it's thought that something similar could be done for ketamine as well. So how does intranasal S-ketamine compare to IV ketamine for depression? So this has been looked at, although there's kind of ongoing debate, but there's a systematic review of 24 RCTs looking at 1,877 participants, and IV ketamine had higher remission rates, lower dropout, and greater overall response than intranasal S-ketamine. So, the IV ketamine being racemic, it has both the S-ketamine and the R-ketamine enantiomers. So there's higher remission rates, so improvements in depression that were more significant, lower dropout, and greater overall response. It's thought that this improvements in that, in many measures seen in IV ketamine folks, racemic ketamine folks, is maybe related to the bioavailability issues. So if you remember, 40 to 60% of intranasal S-ketamine is bioavailable versus IV is 100% bioavailable. It could also be related to R-ketamine antidepressant benefits, which, like I mentioned in the mouse studies, do appear to possibly be at play here, that maybe R-ketamine is more effective than S-ketamine for antidepressant effect. So something important to consider. Another thing to consider is ketamine-assisted psychotherapy. So how does ketamine-assisted psychotherapy compare to ketamine alone? So in some context, folks are given talk therapy in addition to their ketamine or immediately following their ketamine, versus some places where you go and have an infusion suite without talk therapy going along with this. And it's unclear kind of what proportion of the ketamine treatment out there is given with talk therapy and what proportion without. There's a lack of formal head-to-head comparisons of ketamine-assisted psychotherapy versus ketamine alone. But it is thought that there's some synergy here that folks might be missing out on if they're not getting talk therapy in addition with the ketamine treatment. What they're missing out on is there's this neuroplastic synergy. You have the brain-derived neurotrophic factor, you have the secondary messengers, and so it's thought that if you can have therapy immediately afterwards to talk through some things that came up during the trip, or to talk about trauma, you can sort of have new learnings and have your mind be a bit more flexible to integrate some new insights about yourself. So that's a theoretical benefit of ketamine-assisted psychotherapy. Another thing to consider is the dosing, and at lower doses, it's thought that there's sort of a unifying sort of psycholytic or ego-loosening characteristic versus the higher intramuscular doses may have more transformational psychedelic experiences that go a bit beyond just the ego dissolution. So now looking at some other indications other than depression, even though depression is really has a majority of the evidence here, what research has been done on ketamine for PTSD? A few studies looking at ketamine for the treatment of PTSD have been published. Fader and colleagues in 2014 published in JAMA Psychiatry a randomized clinical trial looking at the efficacy of IV ketamine for chronic PTSD, and it was looking at a single infusion of ketamine on PTSD symptom severity and found significant reductions in symptoms compared to placebo. Dichter and colleagues in 2018 they published in Pharmacopsychiatry, and they wrote a review paper looking at potential uses of ketamine as a therapeutic option for PTSD. It was looking at both preclinical and clinical evidence and possible mechanisms of action for PTSD, and kind of, I think raised several points of good evidence why it should be considered for PTSD. And then Wilkinson and colleagues in 2018 published a meta-analysis in the American Journal of Psychiatry where they're focusing on the effects of ketamine on suicidal ideation and looking at basically the potential benefits of ketamine in reducing suicidal ideation in patients with PTSD. So, there is some evidence out there to think that ketamine could be helpful for PTSD. This brings us to another question. What research has been done on ketamine for bipolar disorder? This is a very loaded question because, as I've mentioned before, ketamine is known to be psychotomimetic, meaning that it can simulate, sort of psychosis and may even trigger a psychotic episode. So for this reason, it's a contraindication if you have a history of psychotic episodes to take ketamine. It's contraindicated if you have a history of schizophrenia. However, for folks that have bipolar disorder, as we know, the majority of their experience is in depression rather than mania or psychosis. And so as a result of this, the question is brought up of, should ketamine be considered as a treatment for folks with treatment-resistant bipolar depression? And that's what these two studies look at. So Zarate and colleagues, 2012, published in Biological Psychiatry, a randomized clinical trial looking at the antidepressant effects of ketamine in folks with treatment-resistant bipolar depression, and not surprisingly found that there were significant reductions in depressive symptoms following ketamine administration. And Diaz-Granados and colleagues in 2010 published a randomized clinical trial in General Psychiatry that was looking at ketamine as an add-on treatment for individuals with treatment-resistant bipolar depression, and found that there was a rapid and significant antidepressant effect of ketamine. So what's important here is that ketamine it does not have very significant serotonergic properties, and that's very unique compared to other psychedelics like psilocybin. And it's thought that some of the risk of mania is mediated by the serotonergic properties of other psychedelics. So since ketamine does not have that, it's thought that it may be safer in bipolar disorder. It's probably safe to continue the mood stabilization treatment just in case, to be sure to not accidentally trigger a mood episode. And what's also great about ketamine is that it doesn't have significant interactions with many other psychiatric medications, including medications like lithium or Depakote, or valproic acid. So for folks that would like to, that are looking at this research, I think it's important to, continue the mood stabilization treatment while using the ketamine as a treatment for the bipolar depression. So what research has been done on ketamine for cocaine use disorder? This is really important and interesting research because there's not very good options out there for folks with cocaine use disorder. But this randomized controlled trial of 55 people with cocaine use disorder was published. They were looking at a single ketamine infusion versus midazolam, which is a benzodiazepine infusion, plus 5 weeks of mindfulness-based therapy, and the outcomes were quite impressive. So 48.2% of individuals in the ketamine group maintained abstinence over the last 2 weeks of the trial, compared to just 10.7% in the midazolam group. The ketamine group was 53% less likely to relapse, and their craving scores were 58.1% lower throughout the trial. So it's thought that something about perhaps the synaptic plasticity confers an anti-addictive potential. And then pairing that with mindfulness, so that's a possible mechanism for how it created these benefits. So what adverse effects have been found for ketamine? There are definitely risks of ketamine. There's definitely adverse effects and side effects that need to be noted. It depends a lot on dose and frequency. So for acute frequency or a short-term treatment and at lower doses, what's more commonly seen as mild and transient increases in hemodynamic parameters like heart rate and blood pressure. It's also noted that there's dissociative and psychotomimetic psychedelic effects, and then there's the risk of nausea, vomiting, vertigo, sedation, dizziness, anxiety, and headache. So at chronic lower doses or at chronic higher doses, so like daily use that's seen in folks that abuse ketamine, there's the risk of substance use disorder or dependence occurring. There's risk of impairment of cognition and short-term memory. There's risk of lower urinary tract symptoms, including bladder damage, and there's risk of liver toxicity. So I do want to talk a little bit more about how does ketamine affect the urinary tract. So a systematic review of 61 studies on the clinical use of ketamine had one report of cystitis. So in clinical use, it does appear that these lower urinary tract symptoms are quite rare, versus a UK survey of 1,285 recreational users found that there's a 27% rate of LUTS, or lower urinary tract symptoms. So, these lower urinary tract symptoms are much more common in folks that are abusing ketamine. These symptoms range from more mild, like bladder pain or increased urinary frequency, to more severe, which include hemorrhagic cystitis in chronic recreational users. There is a 3% rate of increased urinary frequency and LUTS in the active group in esketamine trials versus placebo. So again, pretty low risk in clinical populations, but it is recommended to monitor for LUTs in patients with frequent or repeat treatment. So what's the risk of fatality with ketamine? Well, from that perspective, ketamine is considered quite safe in a clinical environment. The fatalities that have occurred have mostly been published in cases, and there's polypharmacy that's typically occurring, or other adulterants like fentanyl. Most of the cases are white males who have polysubstance use disorders, who are using alone. There is an increased risk of disorientation and dizziness when combined with alcohol, and that's certainly one concern for folks that are using at home. Combining with alcohol, there's always a risk with the sedation of vomiting and aspiration, which can be life-threatening, but there's very rare fatality when administered by medical professionals in medical settings. What are the contraindications of ketamine? So if anyone has a hypersensitivity or allergy to ketamine, that's a contraindication. If they have uncontrolled hypertension, if they have severe cardiovascular disease, again, that along with the hypertension is just due to the increase in blood pressure and pulse that's noted in people when they take ketamine. Acute or chronic liver disease, history of psychosis or schizophrenia, like I mentioned, due to the psychotomimetic effects of ketamine. And then current substance use disorders is typically a contraindication, although like we saw in the trial for cocaine use disorder, it is being something that's looked into, and pregnancy and breastfeeding is a contraindication. So what are some conclusions that we can draw about ketamine? Well, S-ketamine is FDA approved for depression, and depression is the most studied psychiatric indication for S-ketamine and racemic ketamine, racemic being the combination of S-ketamine and R-ketamine, which is sort of the cheaper generic version of the medication. Ketamine has good evidence for depression and suicidality. There are perhaps better outcomes with racemic or generic ketamine than S-ketamine, and with ketamine-assisted psychotherapy versus ketamine alone. Ketamine also has some evidence for those with PTSD, cocaine use disorder, bipolar disorder, and other mental illnesses. There are advantages for IM and IV ketamine over PO, namely that there is 90 to 100% bioavailability versus lower bioavailability when taken orally, and then the risk of drug-drug interactions when taken orally. It may be more effective and less risky when ketamine is paired with psychotherapy, although it's not clear how prevalent the practice of ketamine-assisted psychotherapy is. And ketamine has minimal interactions with SSRIs and many other psychiatric medications, which does, which is a benefit versus other psychedelics. The recommended use of ketamine in clinical settings is safer, so it's better to avoid at-home or daily use to prevent ketamine use disorder and also LUTs or lower urinary tract symptoms. All right, so there you have it. That is a crash course in ketamine, the evidence for its possible application for psychiatric illness. And I will be following this with some more information about ketamine, but also about psilocybin, MDMA, and other psychedelics. So please stay tuned with Brain Health with Dr. Nissen, and by following along with me here, wherever you find me. And I look forward to chatting with you again. Thanks.